Thank you, Senior, and good afternoon, everybody. Mm, so, do we have more doctors to join for the session? I can see only 10 doctors.
Yes, I think only 12 of them joined.
So, usually, how many of them joins? So, we already talked about opioids used for mild to moderate pain and opioids for moderate to severe pain. But what we have not covered is the opioid which we use in the third step of WHO analgesic ladder. One of the opioids used in third step of analgesic ladder, that is methadone. So today what we are planning to cover is the pharmacology of methadone, and you might have heard that methadone has many side effects, and how we balance the side effects with the benefits of during pain management. And if there are more risks, how are we going to monitor this patient? Um, and one of the main question asked, which are the patients for whom methadone is beneficial? So we have to identify those group of patients. And most importantly, if we don't know how to convert an opioid to methadone, then this session will not be useful. So we are planning to cover these aspects. Okay. So methadone is available in India as a mixture of two isomers, that is S-methadone and R-methadone. You know that morphine is a strong mu agonist, but methadone acts on all the opioid receptors as agonist. So it acts on mu, kappa, and delta opioid receptors as agonist. And it is also an NMDA antagonist. So which is the NMDA antagonist? You know, anybody?
Ketamine.
Yeah. So ketamine is the usual NMDA antagonist, which usually the anesthetists use. So methadone also has NMDA antagonistic property. Then it inhibits the reuptake of noradrenaline and serotonin. So what other group of medication have this property?
Antipsychotics. Certain.
Antipsychotic. Can you specify which group of medication? Inhibits the reuptake of noradrenaline and serotonin. Anybody else?
Antidepressant?
Yeah, it's
SSRI.
not SSRI. It is tricyclic antidepressants. SSRI means selective serotonin reuptake inhibitors. So it is selective, but tricyclic antidepressants are the group which inhibits the reuptake of noradrenaline as well as serotonin. So that's why we use it in neuropathic pain. We use tricyclic antidepressants for treating neuropathic pain. So methadone has this property also. So you can see it has three properties which are beneficial to treat pain. But there is another mechanism of action. It inhibits the human either a go related gene, that is HERG. This HERG is seen in smooth muscles, but it is abundant in myocardium. So it inhibits this HERG gene, and it can cause torsade points. Once the patient has tossed up points, sometimes it can cause sudden death of the patient. Okay. So the first three is beneficial effect, whereas the last one is uh, more of more of harmful to the patient. So this is the side effect which scares everybody to prescribe methadone. So let's look at the various effects of methadone in detail. So we told that methadone acts as an opioid receptor agonist on all opioid receptors, mu, kappa, and delta. So you know that because of the agonistic action, it can cause analgesic effect. But it can also cause some of the side effects like sedation, constipation, nausea, pruritus, edema, respiratory depression. This is also the same with other opioids. And you can see here for patients who are on thousands of milligrams of morphine. The last patient is taking 12,000 milligram of, that is, patient A is taking 12,000 milligram of morphine equivalent per day, whereas patient D is taking about 1,000 milligram of morphine per day. Uh, so these patients, can anybody tell me what is a tolerance? What is tolerance? Anybody?
Requiring greater dose to achieve the same effect.
Yeah. So you can see, and this is not the usual dose which we see in our patient, isn't it? Here it's 12,000 milligram equivalents of morphine. So that's not the usual dose. This is probably because these patients might have developed tolerance. So one of the mechanism involved in tolerance is NMDA receptors. So if you can block the NMDA receptors, you can prevent and reverse the tolerance. So all these patients, so here you can see that all these patients were started on methadone 10 milligram every 8 hourly, regardless of the dose of the daily dose of morphine equivalent. So each patient A, B, C, and D was started on 10 milligram every 8 hourly, that is 30 milligram per day. And all of these patients got good pain relief. That indicates that uh, this methadone blocks NMDA receptors, or it acts as an NMDA antagonist, which can prevent and reverse the tolerance. So that's one of the good effect to treat the tolerance. And you also know that NMDA antagonists are medications which is useful to treat neuropathic pain. Okay. So these are the two good effects because of the NMDA antagonistic property of methadone. Then we talk that it can inhibit the reuptake of noradrenaline and serotonin, which is the tricyclic antidepressant-like action. And tricyclic antidepressants are used to treat neuropathic pain. So methadone will also be beneficial in patients who has neuropathic pain. But the problem is that when you give methadone along with the medications which can inhibit the reuptake of noradrenaline and serotonin, like here you can see there are many medications like serotonin inhibiting medications, uh, fluoxetine, sertraline, all the antidepressants. So if uh, that can cause something called a serotonin syndrome. Okay, so when you give methadone, please make sure that, or at least you be aware that there are medications which can cause serotonin syndrome, and most of them are antidepressants, which we commonly use in palliative care. That's what it is important. So, how will you diagnose serotonin syndrome? So there are many symptoms by which you can make out the patient has serotonin syndrome. This includes the cognitive changes, autonomic instability, and neuromuscular changes. In cognitive changes, it may range from insomnia to coma. And in autonomic instability, you can see patient will have um, fever, mydriasis, hypothermia, tachycardia, nausea, vomiting, etc. So all the symptoms of autonomic instability. And neuromuscular changes, it can range from trauma to seizures. Be aware that if a patient presents with agitation, hypothermia, tremor, and if you are giving methadone, um, uh, suspect that this might be serotonin syndrome. I have not seen any serotonin syndrome though, but theoretically it is possible. It is not only the problem with methadone, but you also know that tramadol, which also has a tricyclic antidepressant-like action. So tramadol can also cause serotonin syndrome if it is given along with the other antidepressant medications. So we talked about three beneficial effects of methadone. One is because of its action on opioid receptors, then NMDA receptor antagonism, then inhibition of reuptake of noradrenaline and serotonin. Now we are going to talk about um, something harmful with methadone use, which is the action on human either agogo related gene. Okay, so I told you that this HERG gene is abundant in myocardium, and it can increase the QT interval and torsade points and sudden death. So there are some cardiac risk factors which can predispose the individual to torsade points. These are electrolyte abnormalities. So calcium, potassium, and magnesium, hypocalcemia, hypomagnesemia, and hypokalemia. This can cause increased QT interval. And older age, female gender, if the patient has any structural heart disease. And there are some patients who where there is QT prolongation run in families. And if the patient has a previous ECG, which indicates that the QT interval is more than 450 milliseconds. And higher doses of methadone can also cause or increase the risk for torsade points. These are some factors which we have to keep in mind regarding the risk for torsade points. But here is a study done in MD Anderson Cancer Center, and they did a prospective study in 100 cancer patients whom they started on methadone, and they looked at ECG of all these patients at when they started methadone, then after 2 weeks, then 4 weeks, and 8 weeks. And what they found was there were no events of any torsade points or ventricular fibrillation. So there were no clinically significant problem occurred in patients, and they use you can see that the median methadone dose were 23 milligram. So they used maybe less than 40 milligram of methadone per day in all the patients. So what you have to understand is at lower doses, methadone may not cause QT interval prolongation. And most of the studies which indicates that methadone can produce torsade points is on patients with methadone substitution therapy in substance abuse. So they will be on hundreds of milligrams of methadone. So as you know that uh, while the patient is on high dose of methadone, the chance of QT interval prolongation is more. But the doses of methadone to treat the pain is maybe less than 40 milligram per day. That's an average maximum dose. But you can see that there are patients who might take more than this, but usually it will be less than 40 milligram per day. So the chance of QT interval prolongation and torsade points is very, very less. And there are many medications which can cause increased QT interval and torsade points. So you can see these are the common medications which we use in palliative care. There are, you can see that azithromycin, clarithromycin, all the macrolides, then fluoroquinolones, haloperidol, escitalopram, ondansetron, so fluconazole. These all are medications which we use in palliative care. So you can see that the level of risk, it says definitely there is a risk with these medications and possible risk. There is another group and conditional risk. In the conditional risk, you can see there is metoclopramide, pantoprazole, and all the most of the azoles, quetiapine, etc. So when you prescribe methadone for patients, you have to be mindful about these medications. So about the pharmacokinetics of methadone, it is well absorbed orally. And you can see about 80%. The bioavailability of methadone is about 80%. What is the bioavailability of morphine? Can anybody tell? Anybody? Bioavailability of morphine? Please make a guess. Okay. So the bioavailability of morphine is only 20 to 30%. But here, methadone has a bioavailability of 80%. And please tell me whether morphine can be administered sublingually. Can we administer morphine sublingually? Anybody? Anybody? Morphine? Yeah. Yeah. So I can see there are a few answers. No. Yeah. So usually morphine is not advisable to give sublingually because it is not fat soluble and we don't know how long it is going to take absorb from the sublingual route. And if somebody gets pain relief after sublingual administration, that means the patient has swallowed it. So it is not usually advisable to give morphine sublingually, but methadone can be given sublingually. Like morphine, you can also administer methadone directly. And the metabolism happens mainly in liver. Um, and then it is distributed whole through the body and is excreted mainly through bowel, but a fraction is also excreted through kidney. The metabolism of methadone is important. Uh, okay, so the metabolism, it occurs mainly in liver. You can see there are various cytochrome P enzymes are involved. Cytochrome P, 2B6, 2D6, 2C7, 19, and there are many cytochrome P enzymes involved. So we know that the, many medications, these are metabolized in liver. So there is a chance that there can be interactions with this medication. Most of the medications which we use can have interaction with methadone. So that's one thing that you need to be careful. Okay. Uh, and once it is administered, then what happens to the methadone? It will be there in the blood for some time, maybe up to 2 to 4 hours. But after this, methadone will be going and it will be stored in the cells. Okay, so it will go inside each cells. So this is what happens. You can see when you administer methadone, that will go and it will go into the cell where it binds to the tissue binding sites. So once this tissue binding sites are saturated, then the methadone will be liberated into the blood, okay, for systemic action. So if you start a patient first time on methadone, this is what is going to happen. Uh, Maybe for first few days, there will not be much free methadone in the blood, and that may not give pain relief also because of that. But after 5 to 7 days, that's the time required for the tissue binding sites to get saturated and the free fraction will be liberated into the blood. So 5 to 7 days, or it will take about 5 to 7 days to get good pain relief for the patient. So for the first 5 days, we have to continue the patient on the opioid which he was taking previously, not on a regular basis, but on a if the patient was on morphine, give morphine 4 hourly on SOS basis. And uh, the half-life of methadone is about 22 hours, and all the opioids requires at least 5 half-lives to have a sustained blood level. So because of that 5 half-lives, you can roughly take it as 5 days. So it is methadone will take about 5 days to have a sustained blood level. So in normal healthy patients, it will take about 5 to 7 days. Whereas if the patient is elderly or if the patient has liver problems, then it will take more time, maybe up to 2 weeks. So in patients who are elderly and patients with liver diseases, you have to wait for up to 2 weeks before you increase the dose of methadone. Okay, and I told you that it is methadone is metabolized mainly in liver, and due to that itself, there can be many interactions. There are many medications which can actually increase or decrease the level of methadone. So the medicines which inhibits the cytochrome P can cause increased blood level of methadone. So these are protease inhibitors. What are protease inhibitors? Can anybody tell me? What are protease inhibitors? So these are medications used to treat as an antiretroviral therapy. Okay. And as well antifungals like fluconazole, then cyclosporin, cimetidine, macrolide antibiotics, amiodarone, and non-DHP calcium channel blockers like diltiazem and verapamil. So these are cytochrome P inhibitors, and this can actually increase the methadone level. So if you are planning to give cytochrome P inhibitors, these are strong inhibitors. So you have to reduce the dose of methadone by 25 to 30%. But there are some medications which can also reduce the blood level of methadone. So these are carbamazepine, rifampicin, oxcarbamazepine, phenobarbital, phenytoin, and smoking. So in these patients, if the methadone level is in blood is decreased, that can, if it is decreased so much, that can cause withdrawal reaction. So you have to be, you have to observe the patient whether there is any withdrawal symptoms. Otherwise, you need not do or you need not increase the dose of methadone, but observe the patient for any withdrawal symptoms. So you can see there are many medications which can increase the methadone levels. Here you can see most of the medications are those which we use in palliative care usually. Amitriptyline, citalopram, escitalopram, antidepressants, other antidepressants, fluoxetine, fluoxamine, sertraline, then omeprazole, esomeprazole, cotrimoxazole, ciprofloxacin, erythromycin. So all these medications can increase the blood level of methadone. And there are some medications which can reduce the methadone levels. So out of this, rifampicin, then phenytoin, carbamazepine, phenobarbital, these are usual medication which we see in patients. So there are a lot of medication which can cause interaction with methadone. That's what we need to know. Nobody will be able to remember all these medications. Okay. Now we are moving on to the appropriate candidates for methadone, or what are the indications for methadone. If you use methadone in small amounts, then it is called as an adjuvant use. Even though we know that this will not correctly fit into the definition of adjuvant. Suppose a patient is on morphine, 20 milligram 4 hourly, and the patient doesn't have proper pain relief. But if you add a small amount of methadone, maybe 1 milligram BD or 2.5 milligram BD, and if the patient has good pain relief, then that is called as an adjuvant in that situation. Then if the pain is refractory to other opiates, we know that all the pain will not be responsive to morphine or fentanyl or any other opioids. So in such situation, maybe you can switch over to methadone. Then if the patient has significant renal impairment, then methadone can be used, because most of the methadone is excreted from the body through fecal route. And sometimes some patients may not be able to take morphine every 4 hourly, and there will be breakthrough pain in between. So in such cases, you can use methadone, because the duration of action of methadone is 8 to 12 hours, whereas the duration of action of morphine is about 4 hours. So if the patient needs a long-acting opioid, then methadone is good one. Then which we already discussed is opioid tolerance or opioid induced hyperalgesia. So if the patient is on high dose of morphine, and we need to increase the dose very frequently, then the patient, we can think that this patient might have developed opioid tolerance. And in such instances, methadone is a good choice. Then if the patient has opioid toxicities, Then if the patient has allergy to other opioids, then also methadone is a good choice. So these are the indications for which you can use methadone. So there are some inappropriate candidates. Family history of sudden death, because congenital QT syndromes can run in families and it can cause sudden death. And if the corrected QT interval is more than 500 milliseconds, then do not start patients on methadone. If the patient is living alone, then that methadone may not be a good choice. And if you are unable to follow up the patient, then for acute pain, you know that it will take about 5 to 7 days to have good pain relief. So in acute pain, methadone is not advisable. So then how do you monitor the patient? We talked about increasing QT interval, Torsade points. How can we monitor these patients? First of all, what we have to understand is the investigations should be based on goals of care. Uh, if we are looking at comfort care only, then we may not go for much investigation. But if the patient is on curative treatment, you have to do baseline investigation. So what are the baseline investigations? You need to do an ECG to look for corrected QT interval. So corrected QT interval can be calculated uh, uh, by measuring heart rate and QT interval. And there are many apps available for that. So just enter the values, you will get a corrected QT interval. Then I told you that hypokalemia, hypomagnesemia, and hypocalcemia, all this can cause increased QT interval. So just investigate for the level of calcium, potassium, and magnesium. And then during follow-up, you can take an ECG after 2 to 4 weeks. And then once the dose reaches 30 to 40 milligram, you can do another ECG. And if if you have reached up to 100 milligram, then another ECG to look for QT interval. And if the patient develops any new risk factors, then you have to do an ECG. And most importantly, what you have to understand is methadone will take 5 to 7 days for to reach the steady state concentration in the blood. And if the patient is elderly and if they have liver impairment, then it will take more time, up to 2 weeks. So wait till this time to increase the dose of methadone. So it is not like morphine. Morphine we can actually increase every day, maybe within 24 to 36 hours, the morphine blood level will be stabilized. But methadone will take about 5 to 7 days. So these are the preparations of methadone available in India, tablets as well as syrup. Tablet is 5 milligram and syrup 1 ml containing 5 milligram. Only one pharmaceuticals produce methadone in India, and this is known as RMeth. And now we are moving on to conversions of methadone. One of the most important thing that you have to understand is there is no linear relationship between morphine dose and methadone dose. It is not proportional. If I ask you to convert 400 milligram of tramadol to morphine, what would be the equivalent dose? 400 milligram of tramadol to morphine? Anybody? What is the potency of tramadol? Yeah, 400 milligram is equivalent to 40 milligram. Okay, yeah, that's correct. So the potency of tramadol is it is 1 by 10 plus potent as morphine. So for 400 milligram of tramadol is equal to 40 milligram. 300 milligram is equal to 30 milligram. 200 milligram is equal to 20 milligram. But this is not in case of methadone. You will not be able to, or there is no linear relationship or linear potency for corresponding dose of morphine. It varies with dose of morphine that you are administering. Okay. So this is the conversion factor that we can use for converting from an opioid to methadone. If the patient is opioid naive, or if the patient is taking less than 60 milligram of oral morphine, then you may use 1 milligram 12 hourly to 2.5 milligram 8 hourly. That is 2 milligram to 7.5 milligram in 24 hours. And if the patient is taking 60 to 199 milligram of oral morphine equivalent per day, and patient is less than 65 years old, then conversion ratio is 10:1. That is 10 milligram of oral morphine will be equivalent to 1 milligram of methadone. And if the patient is taking more than 200 milligram of oral morphine, or if the patient is more than 65 years, then the ratio, conversion ratio is 20:1. So this is what I told you. There is no linear relationship between the dose of morphine and methadone. Okay. If you look at the literature, there are many methods by which you can convert an opioid to methadone. But I think this will be the simplest method, which came as a result of consensus of hospice and palliative care people, and this was published in Journal of Pain Symptom Management in 2019. And if you want to increase the dose of methadone, you have to wait for at least 5 to 7 days in patients who has normal liver function. Okay, and you can increase by 5 milligram if the total dose of the methadone is less than 30 milligrams per day. So if the patient is taking less than 30 milligram of methadone per day, you can increase 5 milligram and wait for another 5 to 7 days before you increase the dose of methadone. If the patient is taking more than 30 milligram per day, increase by 10 milligram and wait for another 5 to 7 days. So as I told you, one of the most important thing that you have to keep in your mind is never increase the dose of methadone before 5 to 7 days, because that's the time required for the methadone to saturate the tissue binding sites, and then thereafter only the free fraction of methadone will be liberated into the blood. So now we'll move on to some patients. Okay. So this is a 37-year-old man who was diagnosed with carcinoma of the buccal mucosa in 2018. And immediately after that diagnosis, he had another primary, that is papillary carcinoma of the thyroid, for which he underwent surgery and radiation. And in 2019, he had a nodal recurrence for which he underwent surgery again. So you can see the patient here who is sitting with his head down because of severe pain. So he described that his pain is starting inside the left ear, going to lateral side of forehead, then to submental region. He described it as a pricking type of pain, which is the worst imaginable pain. And you can see the pain distribution. It is in the area of mandibular nerve here. Okay, and because of this neuropathic pain involvement, he underwent extraoral mandibular nerve block from an institution 3 times but he had no relief for the pain. And because he didn't have any relief, they tried to started him on injection morphine, but he developed toxicities of morphine. And then he was started on a lesser dose of morphine, like this: 10 milligram, 15 milligram, 10 milligram, and 30 milligram with 10 milligram SIS dose. Even with this, he had toxicities. And he was also tried on various adjuvants, but there were no pain relief. The patient is on these medications: tab morphine, pantoprazole, ciprofloxacin, acetylopram, serratiopeptidase, diclofenac patch, tab paracetamol, 650 milligram, 1 SIS. So is this patient a candidate for methadone? Is this a patient for methadone? Anybody? Yes, as an adjunct. Okay, I can see 3 years. So if this patient is a candidate for methadone, what are the indications to start methadone in this patient? What are the indications to start methadone in this patient? Patient is not on high dose of morphine, isn't it? These are the medication he is using. He's taking only 65 milligram of morphine. So yeah, yes, morphine toxicity, neuropathic pain, intolerance of morphine, severe pain, yeah, toxicity, yeah. So those are the a few indications to start patient on methadone. Okay, good. So as you told, there is complex neuropathic pain, which is even not relieved with interventional pain management. Then as you told, morphine toxicity, and it is not responding to morphine properly. So these are the indication to start methadone. So before starting methadone, what all would you like to do for this patient? So I told you before prescribing methadone, you have to find out certain details and you have to do some investigation. So what are those things that you are going to do for this patient? Yeah, ECG, toxicity, family history. Yes, sodium, potassium, calcium, magnesium, LFT. Okay. Um, okay. Uh, so you have to ask, is there any history of sudden unexplained death in the family? Because I told you, congenital QT syndrome can run in families. And you have to also look for a reliable caregiver. If there is no reliable caregiver, you should not start patient on methadone. And ECG, then electrolytes, that is potassium, calcium, and magnesium. But this patient is not on any curative treatment. He has two primaries and he has recurrence, and oncologist told him there is nothing from the oncology side. So this patient is mainly on for comfort care. So the goals of care is what we are looking at. So if the goal of care is comfort care only, then ECG and electrolytes may not be warranted. But if you are going to start a patient on methadone for the first time, it will be good to have ECG and electrolytes. Okay. So do you have any concern with the present medication? These are the medications the patient is receiving. Any concern with this medication? Okay, and Dr. Girija says citalopram. Yes. Ciprofloxacin, yeah, ciprofloxacin, citalopram, yeah, pantoprazole. Okay, so citalopram, pantoprazole, and ciprofloxacin. These are medications which have interaction with methadone. Okay, so now we understand that there is some interaction with methadone. So how are you going to calculate the dose of methadone? How do you calculate? These are the medications he is receiving. So first of all, you have to calculate that oral morphine equivalent dose per day. So this patient is receiving total 65 milligram. Okay. So what would be the conversion ratio? Anybody? Yeah, 1 milligram 12 hourly should be okay. Anybody else? What should be the conversion factor? We told that if the patient is taking less than 10 is to 1. Yeah, if the patient is taking less than 60 milligram per day, you can start 2 milligram to 7.5 milligram per day. If patient is taking 60 to 199 milligram, then the conversion ratio is 10 is to 1. Okay, and his age is 39 years. So oral morphine is equivalent is between 60 to 199. So conversion factor is 10 is to 1. So the dose of methadone that you are going to start is 6.5 milligram. And if you have if you have only tablet methadone, then start him on 2.5 milligram BD. Or if you have syrup, then you can start with 3 milligram BD. But you have to also prescribe morphine 10 the previous dose he was taking 10 15 10 30 so we are regularizing morphine, not regularizing, we are giving morphine 10 milligram 4-hourly SOS dose. If you write or prescribe morphine for a patient, it will be morphine 10 milligram 4-hourly and SOS. But here it is not 4-hourly and SOS. It is only 4-hourly SOS dose. That means if you give, suppose you are giving methadone at 6 a.m., you will ask the patient whether you have pain. If the patient has pain, you can give morphine 10 milligram. At 10 a.m., you can again ask, do you have pain? Patient says, no, I don't have pain. You will not give morphine. 2 p.m., you again ask. 6 p.m., 10 p.m., you will ask. And if the patient has pain, you will give morphine. Otherwise, you will not give. So in this patient, we also had some concern with other medication. So you calculated the dose of methadone 2.5 milligram BD or syrup 3 milligram BD with morphine 10 milligram Q for H and Q for H SOS basis. Then paracetamol was continued, and instead of ciprofloxacin, amoxicillin was added, which doesn't have interaction with methadone. And patient was also put on bisoprolol. Actually, this patient was didn't had any depression, so we didn't give citalopram for this patient. Okay, so the next patient is a 39-year-old woman with carcinoma of the pancreas with multiple metastases to liver, lung, and spleen. And she received 5 cycles of chemotherapy, but thereafter the oncologist asked them to stop the chemotherapy because of progressive disease. And she was receiving palliative care from the oncologist, and she was getting medications for pain. So you can see her pain pattern. It starts on the left lateral chest and spread out to back. And it is mostly 10 by 10, and it is stabbing type of pain. When she takes morphine plus tramadol plus paracetamol, she gets some pain relief, that is from 10 by 10 to 8 by 10. In addition, she also complains of myoclonus. So these are the medications that she is receiving. Have morphine 20 milligram 6 hourly, injection tramadol 100 milligram TID, paracetamol 1 gram IV 6 hourly, gabapentin 100 milligram TID, amitriptyline 25 milligram HS, and bisoprolol. Is this patient a candidate for methadone? Anybody? Okay. If this patient is a candidate for methadone, what are the indications for starting methadone in this patient? What are the indications? What are the indications for starting methadone? Anybody? That is, she doesn't have complete pain relief. Why tramadol and morphine simultaneously? Yeah, that's a good question. But oncologist gave her tramadol and morphine that way. We don't know. She was both on tramadol and morphine when we saw her. Okay, breakthrough pain complex regime. Okay, so indication to start methadone. Patient had opioid toxicity, isn't it? She had myoclonus. Then she had, it appears to be a neuropathic pain, and it's not responding to opioids. So those are the indication to start methadone. Do we need to do any investigation? What would be the goal of care in this patient? It's only comfort care. So you need not do any investigations, but if you want to do, you can do an ECG, calcium, potassium, and magnesium. So what is the dose of um, methadone this patient need? These are the medications she is receiving. What is the dose of methadone? 1 milligram 12 hourly, 4 milligram BD, Dr. Revati says. Okay, so Dr. Revati, can you explain how did you get 4 milligram BD? Dr. Sharon says 2.5 milligram 8 hourly. So can anybody tell how did you get this dosage? Dr. Vandana says 5 milligram BD. Please unmute and speak. Okay. Total.
Sir,
Yeah.
can I answer, sir?
Yes.
This
Yes.
is
Please.
Dr. Vandana, sir.
Yes, please.
Sir, the patient is receiving 20 milligrams of morphine 6 hourly.
Yeah.
So we give double the dose in the night
Yeah.
of HS. So
Yeah,
the total
yeah.
dose comes to 100 mg for the
Yeah.
whole day. So as per the guidelines, it is 1/10 of the dose.
Okay.
So 100 divided by 10, it becomes 10 mg, which we are dividing BD. mg BD. That is how I calculated, sir.
Okay. Thank you. So this patient is taking 20 milligram, sorry, 20 milligram 6 hourly, isn't it? So total dose of morphine she is receiving per day is 80 milligram. Okay, only 6 hourly. So 20, 20, 20, 4 times. That is 80 milligram. But she is also receiving tramadol, which is also an opioid, which you have to convert into morphine equivalent. That is oral morphine equivalent of tramadol. That is, she is receiving 100 milligram TID. That is total 300 milligram per day. So the conversion ratio is 1 by 10. So that will come to 30 milligram. So total 30 milligram of morphine equivalent for the tramadol. So total oral morphine equivalent she is receiving 80 plus 30, that is 110 milligram. Okay, and conversion ratio, the patient is 39-year-old and she is receiving the dosage between 60 to 199 milligram. So the conversion ratio is 10:1. So 110 divided by 10, it is 11 milligram. So maybe you can start with methadone 5 milligram BD. Do you have any concerns with the present medication?
Amitriptyline patient is receiving, which again increases the dose of methadone.
Yeah, it can increase the QT interval. So, but she is receiving only a small dose, 25 milligram. So you can continue amitriptyline, or if you want, you can stop. So this patient was started on tab methadone 5 milligram BD with morphine 20 milligram Q4H on an SOS basis, along with the other medication. This patient had a very good pain relief for 2 months. So all these are real stories. This patient was actually finding it very difficult to move from the room. She was a very young lady with 2 kids, who always wanted to take care of her children, but she was unable, and she was very much depressed because of that. She is unable to do anything for her husband and children. But after this, she was actually going out and doing all the activities. And the 2 months, that's her time during which she enjoyed her life. And I think she died after about 2.5 months after starting methadone. And now we'll move on to another patient, a 40-year-old man with advanced malignancy of lung with spine metastasis, who got compression at spinal cord compression at T12 level. And his main complaint is burning pain on both lower limbs, which is continuous and 9/10. This patient is already on 40 milligram of morphine 4 hourly. There is no pain relief. If you want to suppose there are a lot of choice for pain relief in this patient, but if you want to convert this patient to methadone, what would be the dosage? Dose of methadone. Eight milligram BD. Okay. Any other answers? Okay. You can correct it, Dr. Vashigar. Anybody else? Twelve milligram BD. Yeah. Let's see. So this patient is taking oral morphine equivalent of 240 milligram per day. What should be the conversion factor? It should be 20:1, because if the patient is taking more than 199 milligram per day, or if the patient is more than 65 years, the conversion ratio is 20:1. So it is 12 milligram. So you can start either with, if you have only tablet, start with tab methadone 5 milligram BD or syrup methadone 4 milligram TID, along with tab morphine 40 milligram on a 4 hourly SOS basis, along with bisacodyl. Okay. So if you want to know more about the cytochrome P interaction, which are the medications, these are some sites you can visit. And QT prolongation, you can go into crediblemeds.org, which will give you the medications which can interact with methadone. So methadone is actually a good medication for patients with poor be actually good pain relief. And I am sure there will be maybe at least 10% of patients who do not have who do not have proper pain relief with other medications. So those patients we can give good pain relief with methadone. But a few things which you have to keep in mind are methadone has many interactions. So there are some strong inhibitors as well as inducers of cytochrome P enzymes. So just keep in mind, if the patient is taking strong inducers or inhibitors, you have to titrate the dose of methadone according to that. And methadone will take about 5 to 7 days to have a sustained blood level. So don't increase the dose of methadone before 5 to 7 days. It's not like morphine. So we should wait for at least 5 to 7 days. Then the need of ECG, calcium, potassium, and magnesium, that you have to decide according to the goals of care. Yeah. Okay, thank you. Yes, Dr. Sharon.
Yes, actually, I had a question regarding that case scenario, the first one,
Yeah.
case one. You had mentioned there at the end, so when we've converted, we've started on methadone, but we are still continuing the morphine, if I'm not mistaken, for that. But then in the history, one of the indications that we noted for methadone was morphine toxicity. So I think I'm still not able to understand when do you, in which patients do you stop the morphine and continue only methadone? in which patients you continue both? I mean, that is what I'm still not able to understand.
What you have to understand, if the patient has morphine toxicity, then you would start with methadone. Then you will not give regularly morphine. That is 4-hourly morphine you are not going to give. You are going to give only on 4-hourly SOS basis. If the suppose the patient is at the methadone dose is 5 milligram BD, so you have given 5 milligram in the morning, and at that time you will ask the patient, do you have pain? Patient says, I don't have pain. You will not give morphine. Okay. Then at 10 a.m. you will again ask the patient, do you have pain? Patient says, yes, I have pain. You will give 10 milligram of morphine. 2 p.m. You will again ask. Patient says, no, I don't have pain. You will not give morphine. So it is not regular dose of morphine you are giving. It's only on SOS basis. So along with methadone, you will give on morphine 4-hourly SOS basis only.
Oh, okay, sure. Yes, thank you. So in basically methadone, you don't have any SOS for methadone, no?
Some people have a practice of giving methadone as SOS dose, but I think for this methadone is a new medication in India, and it would not be good to use methadone as SOS. Uh, yeah. So can pain be resistant to methadone? That's also possible. But if you select the patient carefully, we told that these are the some indication to start methadone. So you can give methadone as an adjunct. If the patient has opioid toxicities, use methadone. If the patient has complex neuropathic pain, that's also another indication. If the patient has pain with renal failure, because methadone is excreted from the body mainly through fecal route. That's also another indication. Then patient with opioid tolerance, as well as patient with hyperalgesia, opioid-induced hyperalgesia. So these are some indications for methadone. If you select patients like this, I think most of the patients will have pain relief. Yes, we are giving morphine because methadone will take time, about 5 to 7 days to have a sustained blood level. That's why we are giving morphine on an SOS basis. Okay. So can anybody tell me what is the conversion ratio of methadone? Anybody? So if the patient is taking less than 60 milligram, that is the patient should be considered as an opioid naive patient. Then we should start with 2 milligram to 7.5 milligram per day. 2 to 7.5 milligram per day of methadone. If the patient is taking 60 to 199 milligram, and if the patient is less than 65 years, the conversion ratio is 10:1. Then if the patient is taking more than 199 milligram of morphine, moral morphine equivalent, or if the patient is more than 65 years, conversion ratio is 20:1. Any more questions? Dr. Girija? So if you have RMI status, you can also purchase methadone with that. Okay. So if you have recognized medical institution status, you can purchase methadone with that RMI status itself. You need not get any other licenses to purchase methadone in India. And if you look at the cost, it is comparable to morphine. It is low cost. Okay, patient on less than 200 milligram with the liver impairment. The ratio is 10:1. Yeah. Um, uh, if you when you calculate the dose of methadone, only the oral morphine equivalent as well as the age of the patient is considered. But when you increase the dose of methadone, then if the patient is elderly or if the patient has liver impairment, then it is better to wait for 2 weeks. So Senia, I don't see any more questions.
Sir, unfortunately, we don't have a case presentation today.
Okay. Yeah.
There are more questions. We can wind up today's session. Thank you, Dr. Sunil, for that wonderful session, for leading us through the session of Methadone. And thank you all for being here with us today for today's session. Thank you all once again. The feedback will be shared in your WhatsApp group. Please go through it and fill it up. Thank you all. We'll see you on the next session. Bye.